Schizophrenia is a chronic disorder that affects approximately 1% of the world's population. The illness results in a generalized and substantial cognitive impairment. Symptoms of schizophrenia have traditionally been classified into five main dimensions: disorganization, anxiety and depression, grandiosity and excitement, negative symptoms which include alogia and emotional withdrawal, and the positive symptoms which include delusion and hallucinations. There are many theories relating to the causes of schizophrenia. The most common relate to the neurotransmitters dopamine and glutamate. The dopamine theory of schizophrenia hypothesizes that elevated striatal dopamine synthesis capacity and increased dopamine release, often as a result of stress, are responsible for the positive symptoms of schizophrenia. The glutamate hypothesis proposes that communication between the thalamus and the cortex in people with schizophrenia is altered due to a blockage of a glutamatergic NMDA receptor. This produces hyperpolarization, which results in the bursting of calcium channels. The thalamus is responsible for sensory processing, so it is thought that the altered firing between the thalamus and the brain's cortical networks is responsible for the positive symptoms of schizophrenia. The illness has traditionally been treated with antipsychotic medications, usually combined with some sort of social intervention or support. tDCS is a schizophrenia treatment option that has been around since the 1960s, though it was called brain polarization back then, and it did lose its way in the 1970s before re-emerging at the turn of the century. tDCS involves the emission of a weak electrical current, traditionally via the placement of two electrodes attached to the scalp of a participant. During stimulation, current flows between the electrodes, passing through the brain to complete the circuit. The direction of current flow differentiates a nodal and cathodal stimulation by modulating the resting membrane potential of the neurons stimulated. A nodal stimulation depolarizes the neurons, increasing the probability of action potentials occurring. Cathodal stimulation hyperpolarizes the neurons, thus decreasing the likelihood of those action potentials occurring. Ascertaining whether the overstimulation of dopamine or the inhibition of glutamate is the neurobiological root cause of the individual's schizophrenia is not an exact science, and the available literature appears to suggest that there is a lot of trial and error within the process of determining which stimulation parameters to implement in tDCS treatment. Despite the two theories arguing for different stimulation parameters, there appears to be consensus amongst most researchers that tDCS is beneficial in reducing the positive symptoms of schizophrenia, including the visual and auditory hallucinations, as well as some catatonic symptoms. Whilst the literature does acknowledge significant reduction in the positive symptoms of schizophrenia post tDCS interventions, there is, however, no consistent information available regarding the optimal stimulation parameters. For example, there appears to be no significant agreement on factors pertaining to the intensity, the duration, the number of sessions, or even the interval between sessions relating to tDCS treatment for schizophrenia. Another area that appears to be gaining the attention of researchers is the fact that there is very little data on the interaction between antipsychotic pharmacological treatments and tDCS in patients with schizophrenia. It has been demonstrated previously that dopaminergic, serotonergic, and GABAergic agents all influence tDCS effects on motor cortex excitability. For example, we know that benzodiazepine has a detrimental effect on bifrontal tDCS efficacy in major depression. With most schizophrenia sufferers also undertaking pharmacological interventions, including medications that bind to dopamine receptors, it has been noted amongst several researchers that this is likely to influence tDCS efficacy. Another area that some researchers are exploring relates to the variable of smoking cigarettes. Tobacco use disorder is a common comorbidity in patients with schizophrenia, and the rate of smokers in patients with the illness is significantly higher than the general population or within other psychiatric illnesses. It is known that smoking leads to stimulation of acetylcholine receptors, which leads to enhanced thalamocortical functional connectivity and dopamine release regulation. tDCS is attempting to manipulate two neurological functions that are already being altered by the body's neurological response to nicotine, amongst other chemicals. This, of course, raises concerns about the efficacy of tDCS when other variables are known to be exciting or inhibiting neurons. It isn't just smoking and acetylcholine receptors either. Researchers have made a connection recently between the hormone estrogen and its ability to directly target dopamine neurons and stimulate the expression of tyrosine hydroxylase, the key enzyme in dopamine synthesis. Thus, when a female patient with schizophrenia receives tDCS, there are multiple variables interfering with the neurological mechanisms that the tDCS is attempting to manipulate. Future research pertaining to tDCS and schizophrenia has some way to go in terms of managing and even understanding the intricate effect that variables like medication, nicotine, and hormones have on the cortical and subcortical brain areas that tDCS treatment is also interfering with. Future research will no doubt continue to explore these relationships. For now, though, the success of tDCS appears to be based primarily on observed and self-reported reductions in the positive symptoms of the schizophrenia sufferer post tDCS treatment intervention.